Hello, and welcome to this program entitled FcRn Inhibition for the Treatment of Generalized Myasthenia Gravis, Patient Selection, Tailoring Dosing Regimens, Updated Disease Management Paradigms. This program is supported by an educational grant from Argenx and is provided by Academic CME. I'm James Howard, Chip Howard to some of you, Professor of Neurology, Medicine, the University of North Carolina School of Medicine in Chapel Hill. And I'm joined by my colleague, Nicholas Silvestri, Clinical Professor of Neurology and Assistant Dean for Student and Academic Affairs at the Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York. Welcome, Nick.
Thanks, Chip. Always a pleasure to work with you.
All right, well, let's get started. Myasthenia gravis, it's a chronic antibody-dependent, complement-mediated autoimmune disorder of neuromuscular transmission. Characteristically, one sees variable fluctuating muscle weakness and exertional muscle fatigue, first identified by Sir Thomas Willis 2-3 centuries ago. There are multiple effector antibodies targeting one, the acetylcholine receptor in about 83 to 85% of our patients, another to muscle-specific kinase, or MuSK as we call it, in about 8%, and then very rarely to lipoprotein receptor-related protein 4, or LRP4, in less than 1%. And then there's a subpopulation for which we've yet to identify an antibody, and we call them seronegative. We believe that some of them do indeed have antibodies to the acetylcholine receptor, for instance, that we can detect with some research modes of technology. There are at least 3 pathogenic mechanisms of disease. Most commonly, and people are aware of, is the functional blockade of the acetylcholine receptor by autoantibody. Binding to some surface determinant on the receptor complex, it prevents the binding of neurotransmitter acetylcholine to the receptor docking site, which there are 2 docking sites on each receptor protein, and both must be occupied by neurotransmitter in order to open the channel and allow ion flux to occur. One or none bound, that channel stays closed. The second mechanism is that the binding of antibody to the receptor complex activates or accelerates a normal turnover process. We call it antigenic modulation, in which there is cross-linking, there is internalization of the receptor complex, and degradation. Now, this happens normally, depending upon muscle, depending upon species, but on average, somewhere between 7 and every 10 days. New receptors pop to the surface. And in the presence of antibody, this is accelerated, so there's a net loss of receptors from the surface of the membrane. Remember that activation of muscle fiber contraction, is dependent upon the depolarization of that muscle membrane, which in turn is dependent upon the number of receptors available to be depolarized. And as we lose them through functional blockade or through antigenic modulation, then that receptor number falls, and we increase the probability that we cannot depolarize that muscle membrane. The third mechanism is complement activation, and the binding of antibody to the receptor complex activates C1q of the complement cascade, which in turn activates and overdrives the terminal complement pathway. C5 cleaves to C5a and C5b. C5b then goes on to combine with molecules of C6, C7, C8, multiple copies of C9 to form what in the old days was called the membrane attack complex. It's now sometimes called the terminal complement complex. And this pore or ring-like structure binding of the surface of tissue literally drills a hole through the tissue membrane, leaks its content, and renders it dysfunctional or afunctional. In the lower right, you see a cartoon demonstrating a normal neuromuscular junction. We have acetylcholine receptors here in orange, with the binding of antibody in gray, and then complement activation here in green. And one sees that the ultimate formation of the membrane attack complex leads to this architectural destruction of the neuromuscular junction. This too reduces the number of acetylcholine receptors available for depolarization, rendering the muscle with increased difficulty to become depolarized and activated. Let's speak about the mechanism of the neonatal Fc receptor. And IgG, as we have known since the 50s through the work of Sir Francis Bramwell, was that IgG was salvaged and transferred across the placenta to the fetus, thus giving the fetus and the neonate an immune system at birth. IgG molecules are pinocytosed by the cell. They are bound very tightly to the neonatal Fc receptor and then transported back to the surface of the membrane and re-released into the vascular space. Immunoglobulin that is not bound to FcRn is then shunted to the lysosome here, where it is destroyed. And it became apparent that the presence of the neonatal Fc receptor was ubiquitous in many tissues, including the vascular endothelium. And it was found that we could manipulate this system through the elegant work of Sally Ward and others. And she created what were called ABDEGs, antibodies that enhance IgG degradation, and found that one could bind to FcRn with very high affinity in acidic pHs that then would block the binding of immunoglobulin to the FcRn molecule. And as shown here on the right, we have pinocytosis internalization, but the neonatal Fc receptor is blocked by these specific antibodies. And so there's increased IgG floating in the cytosol that is now being shunted into the lysosome for destruction, and many fewer are being recycled back to the membrane surface and released into circulation. As a result, there are now multiple parties interested in the development of antibodies that will selectively target the neonatal Fc receptor to be used as a therapeutic tool in the treatment of many IgG-mediated autoimmune disorders. FcRn clears all subclasses of immunoglobulin G. It does not touch IgM, IgA, IgE, IgD. Depending upon which product, it may have effects on serum albumin and cholesterol levels. They can be administered intravenously or subcutaneously, and these are product specific. And the FDA has approved 2 compounds for use. One is Efgartigimod for AChR positive myasthenia gravis, and then Rozanolixizumab for AChR positive and MuSK positive myasthenia. And as I said earlier, there are several others that are in clinical trials right now, and we have no data to discuss with you. Efgartigimod is a small molecule. It's a human IgG1 Fc fragment. It's a natural ligand of FcRn, but it's been engineered for increased affinity to the FcRn molecule. And it was designed to outcompete endogenous IgG, thereby preventing recycling and promoting lysosomal degradation of IgG without impacting its production. So it targets all IgG subtypes. It has no impact on IgG production. So if one were to come in contact with a pathogen, all of the mechanisms are in place to develop an antibody response to that pathogen. This particular compound has no impact on other immunoglobulins, and there's no impact on serum albumin or an increase in cholesterol levels. It must be remembered that FcRn blockade does not lead to complete IgG removal. None of the compounds will do that. And it's to varying percentages ranging from some 65 to 70, 80% of IgG removal. The ADAPT trial was the pivotal phase 3 trial with Efgartigimod in generalized AChR positive myasthenia gravis. It is an interesting trial for 2 reasons. The regulatory agency, the FDA, allowed 20% of the population to be non-AChR positive, And so there were a few MuSK patients, there were seronegative patients, there was at least one LRP4 patient in this trial. In addition, rather than dosing on a continuous basis, doses were administered cyclically. And this was the result of discussions with patients as to what they wanted, what they needed, and other interested parties in the treatment of this disease. It enrolled patients who had Myasthenia Gravis Foundation disease class 2 mild, 3 moderate, 4 severe, and excluded those who had pure ocular disease class 1 or those who are in crisis class 5 on ventilatory support. And as I said, they were AChR positive, the overwhelming majority, or AChR antibody negative. They had to have a Myasthenia Gravis Activities of Daily Living score, a patient-centric PRO of at least 5. And they had to be on stable myasthenia treatment. And they had to have particular IgG levels. 2 weeks of screening and randomized 1-to-1 to receive intravenous Efgartigimod or placebo. And the schema is here. 4 weekly doses followed by a period of observation, and then when particular criteria were met, they could be retreated as many as 3 times in the blinded portion of the trial. And then patients who completed the trial were allowed to proceed to an open label extension, and that's approaching 3 years in duration. So as I said, the dosing cycle was weekly times 4. It's about a 1-hour infusion. And then individualized treatment cycles based on response to therapy and the clinical examination was determined by the Activities of Daily Living score and how close it approached their original pretreatment score. And that determined whether they could be retreated or not. So they had to be at least 5 weeks since their last infusion. They had to have an ADL score of at least 5, and they had to be within 2 points of that original ADL score to be retreated. This slide depicts the baseline characteristics of the study population. More women than men in the treated arm, and fairly similar results in here in the placebo arm. Their therapy at baseline were pretty much well matched in terms of being on steroids, on those who are non-steroidal immune suppressants, or on a cholinesterase inhibitor. So fairly equal across the board. They had disease duration that was approaching 9 to 10 years, slightly longer in the active drug arm than the placebo. And then this middle bar shows the disease class at screening. So predominantly class 3, very few in class 4. And these are typical of what we see in other clinical trials of MG. The patient who has severe disease tends to be brittle, and they don't make good trial candidates. When we look at our outcome measures, the quantified myasthenia gravis score, the MG-ADL score, one sees that they were evenly matched between active drug and placebo, as shown here. So how did they do? This slide shows that they met the primary criteria, what we call an MG-ADL responder, in almost 70% versus 30% of the placebo arm. MG-ADL responder was defined as having at least a 2-point change in the ADL score, but they had to sustain it for 4 consecutive weeks. If they only did 3 of 4 or 2 of 4, they were not defined as a responder. And one sees that we had a fairly robust response. Approximately 85% of these individuals had the onset of effect within the first 2 weeks of treatment. When we look at the secondary outcome measure, the quantified MG score, and this is essentially a physician's examination rather than a patient-reported outcome measure, we see that there are much less in terms of the placebo arm, many more in the treated arm, 63% here. Their ADL definition was at least a 3-point change, again, sustained for 4 consecutive weeks. Over the last few years, we've developed a new outcome measure called minimal symptom expression. And this is defined as those individuals who have an MG-ADL score of either a 0 or a 1. MG-ADL scores are graded, and lower number implies improvement or better quality of life, better physical examination. And a 0-1 essentially means no active disease whatsoever. And we see that during the first cycle of Efgartigimod, 40% of patients achieved minimal symptom expression versus only 11% in the placebo arm. Now let's look what happens to the IgG level as well as the antibody level in that subpopulation who were AChR positive with repeated courses. Is this reproducible, if you will? And this graphic here on the left, looking at total IgG levels, shows that with repeated administrations over time, that there is a very similar reduction in the circulating total IgG level through here 7 different cycles. And on the right, we see the same for the AChR antibody level. Consistent reductions to very similar degrees in AChR circulating antibody. Here we're looking at similar repeatability at the MG-ADL score on the left and the QMG score here on the right with repeated exposures to the compound, cycles of 4 infusions, if you will. Now, unlike the other where we're looking at data after the last infusion, here we're looking at it prior to their 4th infusion, so after 3 infusions, if you will. And one sees again that we have very reproducible results in the improvement in the MG-ADL score clinically, as well as with the QMG score. You see a term here, CMI, this is clinical meaningful improvement, and it's been defined in the literature as a 2-point change in the MG-ADL score and a 3-point change in the QMG score. And one sees that very readily these patients achieved clinical meaningful improvement with each of their infusions. Well, what happens to other serum chemistries? We said there were concerns that there could be changes in albumin and cholesterol, and with Efgartigimod, we see no change in total albumin here in the primary trial, ADAPT, as well as in ADAPT Plus, which was the open label extension trial. And similarly, there's no change in LDL cholesterol over time in both of these the trials, ADAPT and ADAPT Plus, stating that there is specific involvement of IgG only, and there's no involvement of other functions of FcRn. Albumin is modulated through FcRn as well. That binding site is slightly different than that for IgG. And because I think this is a small fragment, small molecule, we can get very targeted binding to the FcRn molecule, as opposed to a full-size antibody, for instance, that may overlap and interfere with that binding site as well for albumin. Efgartigimod has also been developed as a subcutaneous injection. And so a non-inferiority trial was performed comparing it to the intravenous form of the drug. And through preclinical work, comparable dosing amount was found. Approximately 1,000 milligrams sub-Q was equivalent to 10 milligrams per kilogram intravenously. And one sees here in green the subcutaneous form, in blue is the intravenous form, and we're looking at the reduction in total IgG levels here. And one sees that they're very similar in the overall population, as well as the AChR positive population. Now, the injection is 5.6 cc's, fairly large. And so we borrowed from the oncology space the use of hyaluronidase. And so this compound, the subcutaneous formulation, is co-formulated with hyaluronidase, and it breaks down collagen tissue locally, developing slightly a pocket, if you will, for the 5.6 C injection to reside. And then this quickly dissipates over time. And so this is easily administered, self-administered by the patients over several seconds, about a minute, to make this injection. To the right, we're comparing antibody levels with the IV versus the subcutaneous formulation. Again, green is subcutaneous, blue is intravenous formulation, and they virtually overlap. And so there's no, from a pharmacologic perspective, difference in the ability to clear IgG levels and antibody levels in this cohort of patients. When we look at the subcutaneous formulation and look at our outcome measures, MG-ADL score, the gMG score, and what happens over time, one sees that the MG-ADL responder definition, 2-point change, sustained for 4 consecutive weeks, was virtually identical. And those achieving minimal symptom expression, identical. gMG score, the responders, slightly more in the subcutaneous formulation than in the intravenous formulation. So we consider them essentially equivalent therapeutics. And then looking at the change over time, one sees very similar patterns in the curves to the gMG in terms of the ADL score. I'm going to turn this now over to Dr. Silvestri and have him take you through the second FcRn inhibitor that's available, as well as some clinical case studies. Nick?
Thank you very much, Dr. Howard. That was a fantastic overview of FcRns and the data from the Efgartigimod trials. I'd like to talk a little bit about another FcRn inhibitor that you had mentioned in your presentation, which is Rozanolixizumab. So Rozanolixizumab is another agent that binds to FcRn, inhibiting the recycling of IgG, including pathogenic antibodies, including the acetylcholine receptor antibodies and MuSK antibodies. And unlike Efgartigimod, which is intravenous or a small volume subcutaneous infusion, Rozanolixizumab is a subcutaneous infusion as well, with a slightly higher volume than Efgartigimod, and is given over a little bit of a different cycle, whereas Efgartigimod is a 4-week cycle. Rozanolixizumab is actually a 6-week cycle. So Rozanolixizumab was looked at in a phase 3 trial known as the Myasthenia study. And what you see here are IgG reduction of Rozanolixizumab in that study and in preclinical work. And what you see is that there is a fairly robust reduction in IgG levels that were seen as early as week 1, but proceeded throughout the treatment period and lasted quite a long time as you look out to 14 weeks. And it turns out that this IgG reduction that was seen was also paralleled in some of the outcome measures in terms of MG-ADL reduction over the same time period, as well as other measures such as the gMG, similar to what we saw in the ADAPT trial of Efgartigimod. Now, whereas Efgartigimod in the United States is only approved for the treatment of patients with acetylcholine receptor positive generalized myasthenia gravis, Rozanolixizumab is approved also for the treatment of patients with MuSK antibody positive myasthenia gravis. And what we see here, just focusing in on that MuSK subgroup, is that there was a robust reduction in MG-ADL scores at both doses of the drug used in their clinical trial. You can see actually at the lower dose here, the 7 milligram per kilogram dose, there was an average reduction in the MuSK positive patients of 7.3 and the higher dose of 4.2. But regardless, in both cases, this was a robust reduction compared to placebo, and those patients actually worsened in the MuSK subgroup of the Myasthenia study. So it's nice that we have a number of different agents available to us. Efgartigimod in 2 routes of administration, both intravenous and subcutaneous, as well as Rozanolixizumab in a subcutaneous infusion. And as you mentioned, Dr. Howard, we do have several other FcRn inhibitors in the pipeline, which also may be useful for the treatment of patients with generalized myasthenia gravis over the course of time. Just looking at safety, we'll look at the safety of Efgartigimod here in the ADAPT and the ADAPT Plus trials. You can see generally very well tolerated compared to placebo, and then out to several months in the ADAPT Plus data. If you look towards the bottom, what you can see are the most frequent side effects that were seen in patients treated with Efgartigimod, both in the ADAPT and the ADAPT Plus trials, were infections such as upper respiratory tract infection, nasopharyngitis, urinary tract infection, and to a smaller extent, patients experienced headache, nausea, and diarrhea. This is a very similar safety profile to Rozanolixizumab, although with Rozanolixizumab, there's also a concern for the development of aseptic meningitis, which was seen in a few patients in their phase 3 trial. Now, Dr. Howard did a fantastic job before talking about the nature of the ADAPT trial in terms of cyclic dosing and redosing in the trial if patients met certain criteria that indicated they were worsening in terms of their disease state, specifically looking at the MG-ADL scores. And while very novel and a very innovative trial design, when the FDA approved the medication several years ago, the indication was, again, for treatment for patients with generalized gMG, acetylcholine receptor positive, and the dosing was set as 1 cycle, again, being 4 weekly infusions, and then redosing per clinical guidelines or per clinical decision-making on the part of the physician, the treating physician. And so it allows us to individualize dosing for patients with generalized myasthenia gravis, but it does lead to some questions in terms of how best to utilize this medication, how best to dose it. And so in this section, I'd like to talk about different methods or different ways that we can individualize the care of patients with gMG and when and how to use FcRn antagonists or FcRn blockers. So first, I just want to reset the stage here and reevaluate the treatment goals in myasthenia gravis. Myasthenia gravis, thankfully, has been a treatable disease for many years, although the treatments often have led to side effects which in some cases are worse than the disease itself. And so when it comes to these treatments, we want treatments that are efficacious and treatments that work robustly and perhaps better than some of the treatments that we had available to us even before just a few years ago. And so our goal for treating patients with myasthenia gravis should be few or no symptoms due to myasthenia gravis. And so whether that terminology that we use is minimal manifestation status, which is defined as patients not experiencing symptoms, but maybe we as treating clinicians can find a little bit of weakness on exam, or if it's minimal symptom expression, that term that Dr. Howard defined for us, having an MG-ADL of 1 or even better 0, no symptoms impacting a patient's daily living, this is what we want. We want our patients to be disease-free. But as I mentioned, we want to do it without the burden of side effects. So we want few or no side effects of treatment. And there are some medications that we've used to treat myasthenia gravis for years, such as corticosteroids, that can lead to innumerable side effects. But even minor side effects or tolerability issues should be considered. So for example, some of the immunosuppressant medications that we've used over the years might cause symptoms that we as clinicians might think are minor, such as diarrhea or other symptoms, but can be frankly fairly disabling for patients, can be embarrassing, can really limit their ability to perform activities. And we really need to consider these and determine whether that is acceptable. And I would argue that in many cases, in most cases, it's not. And then finally, we have to think about convenience. So what's easiest for our patients? And in the case of FcRn antagonists, as we talked about a minute ago, they really allow for an individualized approach. And they have multiple routes of administration, as I mentioned as well. And so I think what this really highlights is that the treatment of MG is really not a one-size-fits-all paradigm, that we really have to take many factors into account. And one of those factors that we have to take into account is convenience. And figuring out what is best for our patients so that they frankly can forget they have myasthenia, that they're symptom-free, they're side effect-free, and that their treatment really isn't a burden to them, that they can do the treatment with what suits them best, hopefully at least as least frequently as possible. So when should we be thinking about using FcRn antagonists? And again, I don't think there's a simple answer here. I think that you need to evaluate the patient in front of you, think about various metrics, and determine whether or not one of the FcRn antagonists is appropriate for your patient. So one of those situations might be when other agents have failed. Oral immunosuppressants have been used for years. They sometimes allow us, or really the goal is they allow us to take patients eventually off corticosteroids. But they don't work for everyone. There are many times where patients are put on these agents, and as we taper away their dose of corticosteroids or other bridging therapy, we realize that the full effect of this medication is not acceptable, and we have to think of another option. And this is a case where FcRn antagonists might be considered as the next line. IVIG, again, has been used in myasthenia gravis for many years. It's more often used as an acute therapy, but there are some patients that are on it chronically to control their disease. It may not be robust in its effect. It may help some symptoms, but it may leave people with residual symptoms. And frankly, it may cause side effects too. Intravenous immunoglobulin is known to lead to side effects, particularly infusion-related side effects such as headache and flu-like symptoms, which can be disabling for patients. And so that needs to be considered as well. Complement inhibitors are another class of medication that have been approved recently for the treatment of gMG, and these work fairly well in most, but not all patients. And so if a patient has been put on a complement inhibitor and they don't have the robust response that you're hoping for, perhaps a switch to a medication with a different different mechanism of action would be appropriate for that particular patient. What about when other agents are too risky? So thinking again about the short and long-term risks of corticosteroids. There are patients that perhaps our short-term plan is our corticosteroid use, and our long-term plan may be another agent such as an oral immunosuppressant. But there are certain patient populations where the use of corticosteroids, even in the short term, can be risky. Think of patients with poorly controlled diabetes or poorly controlled hypertension, or the patient that has brittle osteoporosis. Or patients with psychiatric comorbidities such as bipolar disorder, where the use of corticosteroids could be quite risky and frankly endanger a patient due to those medical comorbidities. Or think about the short and long-term risks of oral immunosuppressants. Frankly, we're talking usually more about long-term risks, though I did talk about short-term considerations with oral immunosuppressants a minute ago. Take, for example, the development of gastrointestinal symptoms such as upset stomach and diarrhea on mycophenolate. Long-term risks of oral immunosuppressants not only include the risk of infection, but also the risk of malignancy in many cases. And so, especially in patients that are younger, that may be on these medications for decades to try to control their disease, or in patients with a prior history of malignancy, you might consider them too risky and think of another agent, such as an FcRn antagonist, that doesn't entail these risks to use in your patient population. What about as a bridge? So I kind of hinted to this a minute ago. There are maybe some patients where you want to try an oral immunosuppressant for long-term control of the disease, but you don't want to use corticosteroids or you don't want to use intravenous immunoglobulins because of risks, side effects, and the like. And in these cases, an FcRn antagonist may be actually a better option than use of corticosteroids to spare patients from those potential risks. And finally, first line. I'm not sure that we're here yet in 2024, but I do think it's aspirational and something to think about. Wouldn't it be great if we could give patients efficacious therapies that are convenient and have few short-term side effects and really no long-term side effects that we know of yet, although obviously we're still monitoring them early in their use. I think this is something to think about for the future. My hope is that if asked again to give a talk like this 5 or 10 years down the line, that we are using these agents earlier on in the treatment paradigm once cost considerations and other considerations are dealt with and factored into the treatment paradigm decisions. Now, Dr. Howard again talked about the way the clinical trials were run, specifically the ADAPT trial, but it was also true of the MyCaring study looking at Rozanolixizumab. And there are two real ways that you could consider dosing FcRn antagonists once you decide that the appropriate choice in the treatment of your patient with generalized myasthenia gravis. I call the first approach the on-demand approach, and this really mirrors the clinical trials. And in this approach, patients are given a cycle of treatment and then retreated when symptoms start to emerge. The benefits of this approach is that you're giving patients conceivably the least amount of medication possible to control their disease, and you're individualizing the approach. The downside to this approach is that we really don't want patients to worsen with myasthenia. We want patients to actually have stable disease control. And to ask a patient to call us or to come back to the clinic or the hospital when they're starting to worsen, seems a little counterintuitive or counterproductive, especially in patients that have a history of potentially life-threatening complications of myasthenia, such as respiratory failure leading to crisis, dysphagia, which can lead to aspiration, et cetera. And so this particular approach is not what I employ. I know some of my colleagues employ it, but I think it really takes the right patient to employ this approach. It really takes open lines of communication, really trusting your patient to call you at the first sign of trouble, and really trusting your staff to be able to get patients the medication in a timely manner once they do start to worsen. The other approach, which I've employed in my own practice, I call the induction and maintenance approach. I perhaps have borrowed that term from the oncology space. And as I'll show you in the next slide with a diagram, I initially schedule my patients for 2 or 3 cycles, separated by 4 weeks apart in the case of Efgartigimod, to really knock down IgG levels, to really get control of the disease, to really make sure that patients respond to this form of therapy and like this form of therapy. And then after that, I individualize the dose based on between cycles based on patient response and the durability of the response. And I borrowed this approach really from how we use intravenous immunoglobulins, not only to chronically treat patients with myasthenia gravis, but to treat other neurological disorders such as CIDP. And so here's an example regimen of treatment with Efgartigimod. As I said, for the first 3 cycles, I give people 4 weeks of the treatment as per the label. I wait 4 weeks in between cycles. I typically will do this for 3 cycles. And then after that 3rd cycle, I ask patients, as you approached that next cycle, as you were in week 3 and week 4, as you approached that next cycle of Efgartigimod, did you have any hint your myasthenia was coming back? And I not only ask them this, but I do ask my patients to track their MG-ADL scores, and we're looking at their MG-ADL scores as well. And if patients tell me, you know, Dr. Silvestri, I did feel that, you know, I was starting to have a few minor symptoms towards that next round of infusions, then I'll keep people on every 4-week dosing. If, on the other hand, patients say, didn't feel a thing, felt really great, then I might say, okay, let's try 5 weeks between cycles. Let's try 6 weeks between cycles. Again, talking to patients, seeing how they're doing, open lines of communication, tracking their MG-ADL scores, and really then individualizing that approach. And over the past several years of employing this approach and treating patients with Efgartigimod, what I've learned is that some patients truly do need to be treated every 4 weeks. And some patients I've gotten out to 12 weeks between cycles. So 4 weeks on, 12 weeks off, et cetera. And I think that really does mirror some of the data from the ADAPT trial that we didn't present today, but is available. There was a wide range of necessitating repeat cycles within the ADAPT trial. And I think I've seen this as well in my clinical practice. So this is an example regimen that I found to be quite successful in my own clinical practice, treating many patients now with Efgartigimod. And it's a regimen that I've also employed with Rozanolixizumab, though with some different nuances, again, based on the fact that it's an every 6-week treatment cycle as opposed to every 4-week. So what I'd like to do now is take the opportunity to present a few cases where I've had the opportunity to use Efgartigimod. I'll present 2 cases, and then I'll ask Dr. Howard to present a case of his own. And my first case is a patient, 57-year-old man with a pre-existing hypertension. He initially presented to me with ptosis, diplopia, dysarthria, and hand weakness. He was found to have acetylcholine receptor antibodies in serum. I initially treated him with pyridostigmine and prednisone up to 40 milligrams per day. My hope was also to transition him on to mycophenolate. However, he developed quickly a number of side effects from prednisone: weight gain, Cushing weight appearance, elevation in his pre-existing blood pressure. You remember he has hypertension. He became pre-diabetic and was having acid reflux issues, for which we diagnosed him with GERD. His symptoms secondary to MG persisted over time with MG-ADLs in the 6 to 9 range. I started him on Efgartigimod. At that point, he had a baseline MG-ADL of 8, and after 1 cycle, that dropped to 4. And then after 2 cycles, his MG-ADL dropped to 1, And I can tell you that now after 3 cycles, he's 1 as well. So significant control of his myasthenia gravis with using Efgartigimod, which he's tolerated without side effects. Moreover, at the time of his last clinic visit, we had been tapering his prednisone. I'd been able to taper him down to 10 milligrams per day. And all signs point to being able to slowly taper him off altogether over the course of the next several weeks to months. Another patient that I've treated was a 43-year-old woman with a pre-existing history of anxiety. She's been my patient for several years, presenting with initially ptosis, diplopia, dysarthria, and limb weakness in 2014, found to be antibody positive. She was initially treated with pyridostigmine and prednisone. And my long-term plan in her case was a transsternal thymectomy, which she underwent without complications, I believe, in early 2015. Her symptoms unfortunately persisted despite a thymectomy. After about 18 months, I felt that the thymectomy probably wasn't going to be as beneficial as I'd hoped. I'd been unable to lower her prednisone dose lower than 30 milligrams per day. I initially put her on azathioprine, but after 6 months, her liver function tests kept increasing, so I had to stop it. At her request, I then put her on IVIG. She was on that for on a monthly basis. That allowed me to taper her prednisone to 15 milligrams per day, and her MG-ADL did improve. She went from a 12 to a 6, but I was really unable to lower her IVIG dose or interval without a return of symptoms. And she had side effects from the IVIG, typical and what I spoke about previously, headaches, myalgias, and fatigue. So shortly after Efgartigimod was approved, I stopped IVIG and started her on Efgartigimod. I was able to stop her prednisone or taper her prednisone after 3 cycles, and her latest MG-ADL is 1. She's now on Efgartigimod monotherapy. Dr. Howard, I'd like to turn it over to you and hear about one of your cases, if possible.
Thanks, Nick. And so this case is a 60-year-old who's got a 15-year history of AChR-positive generalized disease based on an exam severe 4A with an ADL score of 16. And below you see his treatment paradigm. It was initially started on high-dose daily prednisone, 1 milligram per kilogram, and with improvement was switched to alternate steroids. He improved, but his ADL score never got below 10. And it was complicated by weight gain, glucose intolerance, and mood change. Therefore, cyclosporin emulsion was added, 5 milligrams per kilogram per day, and that was tapered to 3 mg per kg per day. And his ADL score improved slightly to an 8, but we ran into renal issues with increased creatinine BUN 5 times the upper limit of normal. And ultimately then was changed over to mycophenolate mofetil, 1,500 milligrams every 12 hours, and clearly got even more improved to an ADL score of 4, but then became socially embarrassed, became a hermit because of frequent stooling, multiple times a day in the teens. He just would not leave the house because of this. He was intolerant of therapeutic apheresis, widely fluctuating blood pressures, and an allergy to albumin, and so ultimately placed on intravenous immunoglobulin, necessitating it every 1 to 2 months to maintain mild generalized disease with ADL scores fluctuating between 5 and 8. And this too became complicated with the development of a superior vena cava syndrome from the repeated jugular venous sticks necessary for IVIG access. This individual would not allow a port to be put in for easy access. And the decision then was made to go to Efgartigimod, 10 milligrams per kilo IV, weekly times 4. And what I show you in the left panel is his ADL scores. We started at 10, and with subsequent infusions, 1, 2, 3, and 4, his ADL drops to 3. He's then observed weeks later, and it continues to stabilize around that point. And started to rise. And so at 16 weeks had an ADL score of 6, and it was elected to retreat him. And so by that time, his ADL score was 7, and one sees his sequential infusions, and we're able to drive the ADL score down to 2. And in follow-up thereafter, she achieves minimal symptom expression with ADL scores of 0 or 1. This individual was then followed for months while maintaining this degree of improvement. And I will tell you, and it's not shown here, at around somewhere around 9-10 months with an ADL score of 0, then slowly started to lose it. Crept to 1, about 15 months, it was up to around 2. And so ultimately a decision was to retreat when his ADL score achieved a 3. But this represents or demonstrates how one can use the MG-ADL score as a tool to help guide you along with the history and clinical examination as to when one might be interested in intervening and retreating again. And as Dr. Silvestri mentioned, he has his patients do this at home, and we do as well. And then we can discuss this on the phone, make decisions. Do they need to come in to see us in clinic? Do we need to reinitiate another course of therapy? And during all of this, no side effects at all. So we've made progress. We now have targeted immune suppression through FcRn, through complement inhibition. And the reasons or the effects of this have been that we've been able to reduce adverse event profiles, which to patients represent a huge burden to their life. Unlike all of the therapeutics we use, save prednisone, even that takes at least 3 to 4 weeks to really start working, we have rapid onset of effect within week, 2 weeks of initiating this class of therapeutics. We now have different formulations which go to patient choice, intravenous, subcutaneous injection, subcutaneous infusion. And we now have in safety in pediatric populations, not only for complement inhibition, but we're also seeing that for FcRn inhibition, though that data has not been released to date. We do need agents for rapid pending crisis or myasthenic crisis. Will these work? They work quickly enough. And there are anecdotal reports of benefit in using them as such, but we have no good trial data to support their use. And then what's the safety in childbearing patients? We still don't have good MG data there. Clearly, using an FcRn, one needs to be careful. Remember that the fetus and the infant derive their immune system from mom during the last 2 months of fetal life. And so it's probably not wise to use these in late stages of pregnancy, but could be used in early stages of pregnancy. But we clearly need more scientific data there. Well, I'd like to thank you all for participating in this educational endeavor.